Welcome to the Prospective Doctor podcast, brought to you by MedSchoolCoach. Each week we cover topics related to the pre-med journey to medical school and beyond. From the MCAT to completing your application and from starting medical school to choosing a specialty, our podcast will provide essential information for anyone contemplating a career in medicine.
Hey everyone, thanks so much for joining me. So today is the first day that we're going to kick off the MedSchoolCoach case series, where we're going to talk a little bit about some clinical cases that me or other physicians have seen in their time in practice and discuss some of the important takeaways from these cases and things to remember when you are going through medical school and going through residency, etc. So today for our first case series, I have our very own Dr. James Kelly, who's an ophthalmologist in New York. Dr. Kelly, thanks so much for joining me today.
Thanks for having me.
So Dr. Kelly has a couple cases that he was going to start off by telling us. I'll hand it over to you, Dr. Kelly, and you can describe those cases to us.
Sure, sounds good. So the first one, it was a 35-year-old gentleman who came into the office, and I had seen him previously about 2 years ago, just for routine exams. And he came in, and he was actually pretty nervous. He had just come from the emergency room with the complaint of acute diplopia or acute double vision. So we saw him, and he said that it happened on a Sunday. I was seeing him on a Friday. So for about 5 days, it was on and off. And he noticed that it was one object right next to another object. And again, it was variable. He couldn't really pin down when it would happen, but it would fluctuate throughout the day. And then it continued to get a little bit worse. So on Thursday, he went into the emergency room. They did a CT scan of his head, which, as per the patient, was negative. And they did lab work, which he said was all negative, but of course he didn't bring his labs or his imaging study to the office. So we took a look at him, and he was again experiencing the diplopia or the double vision in the office with me. We checked his vision, as we do all patients, and it was 20/20 in both eyes, so perfect. That was with his glasses with correction. And I noticed with his double vision, when I covered one eye, it would go away. And then when I uncovered that eye, he would start complaining of seeing two again. And I also noticed that his eye movements were full. However, he had something of a horizontal nystagmus. And that means it was basically just like a little bit of a flutter in his eye. So when he would move his eyes, it would kind of shimmer back and forth a little bit. And I was able to pick this up on something called cover uncover. And that's when I was covering one eye, and then I would switch to another eye. Mm-hmm. The rest of his eye exam was unremarkable. His eyes looked healthy, and the back of the eye was fine. His nerves looked very crisp, which is important because he had no signs of papilledema. So the one thing that was important to note was that he was also bipolar, and he was also depressed as well. And upon further questioning, when I was asking him about his medications, he noted that he was on Depakote, and he took an extra Depakote pill on Sunday when this started to happen. What was confusing was that he said that when they checked his Depakote level in the emergency room, that the Depakote levels were normal as per the labs. But he did say that he took too much of it. So at this point, I was concerned about three things. One, that he had some type of mild stroke that would not be picked up on CT scan, that he'd need an MRI, that he had something called myasthenia gravis, which is a disease that can affect the eyes. It's antibodies that attack the nerve junction, starting with the eye muscles, or that this could have still been a Depakote overdose. So I saw him with our neuro-ophthalmology colleague, and we discussed it, and you can actually have Depakote an overdose even if with the normal labs, because it was just a cumulative effect. So we actually had to speak with his psychiatrist to get his Depakote levels down. But that was an interesting case, because if he continued on with the Depakote levels, then he continued to have other neurological issues. And again, it was just more of him being on it for too long at that dose. And the psychiatrist was actually trying to wean him off it a little bit. Mm-hmm. So that was an important one.
Can I ask you real quick,
Sure.
Dr. Kelly? So, what's interesting about that too is since, the lab didn't really help you with your decision making in a way, or really finding what was wrong with this gentleman. It was really the history that he gave you, that he had taken too much. And so that kind of alerted you that maybe the levels were off. If you never received that tidbit of history from him, would you have gotten to the same conclusion, do you think?
Not that quickly. And that's a good point. History is just a really important factor here. If we didn't have that tidbit, we probably would have sent him for an MRI of the brain and orbits, again, looking for any demyelination or, again, maybe a small stroke or something that we missed. Though that would be unlikely, obviously, in a 35-year-old, though not impossible.
Mm-hmm.
And we also would have probably sent for more specific labs for myasthenia, because you can look for those antibodies. And I can guarantee you in an ED department, one visit, they're not going to check for that. That's a more obscure thing to look for.
Sure.
But always on your differential, or always on something that you're looking for when you're having this odd double vision that kind of comes on and off, because myasthenia gravis, you get these intermittent intervals of just fluctuations of vision or double vision.
Mm-hmm. So it would have been more of like a rule out type of process.
Correct.
Yeah.
Yes.
Mm-hmm. Great.
But yeah, no, that was a tough one. And also a kind of a big take home point is with double vision can be caused by a whole bunch of different things. But whenever you have a patient with double vision, that when you cover one eye, it goes away. And then when you remove that cover, it comes back. That's a warning sign that something bad's going on, because dry eyes can cause double vision. You might wake up in the middle of the night and have double vision for a second because your eyes are still, getting used to being up. But if you cover one eye and it goes away, that means the eyes are misaligned. And that points more towards a neurologic issue. And that requires you to pause and think what's going on, because you could be missing something very serious if you don't really take a good look.
Mm-hmm. Yeah, absolutely. Interesting. Thank you.
Mm-hmm. So do you want to do the second one?
Sure.
Okay. So the second one, it was a 55-year-old diabetic hypertensive came into the office. It was my first time seeing him, but he'd been seen before by other physicians in our practice. And he came in, he said he was complaining of left-sided headaches for about 2 to 3 months. And now it was spreading to his right side of his head. And of course, he came in because he wanted glasses to fix his headaches, which again, that's always a very frustrating thing as an ophthalmologist to hear. But so we saw him, and his vision was 20/20. It was perfect. He had no diplopia, no eye alignment issues, no nystagmus, like I mentioned previously. He couldn't really pinpoint his headaches or anything like that, just that they were pretty constant. And then on exam, everything looked fine, and he had no diabetic retinopathy. But what we noticed in his left nerve, in the back of his eye, he had an edematous left nerve. The right nerve was fine. Now, a nerve being swollen or edematous, again, that's always a warning sign. Now, if it were both eyes being swollen, you think, that's papilledema, and that's something that's raising the pressure of the central nervous system. And that means he has to go to the hospital right away for neuroimaging. Mm-hmm. It was a little bit curious because it was just a swollen nerve on one side. So again, luckily, I have a neuro-ophthalmologist in the practice, and we talked about him. So I talked to him a little bit more, and he noted that he had been under a lot of stress. His daughter was in the ICU, and that he had some very high blood pressure readings. Mm. So his blood pressure was under better control. So we were thinking this could have been what we call a non-arteritic ischemic optic neuropathy. And basically what that means, it's a stroke of the optic nerve, and that could happen in hypertensives. Yeah. But it was odd because his vision was good. It was 20/20. And he was having headaches on the same side as the nerve swelling. So we decided, we were talking about it some more, and it just didn't add up. And we didn't want to just assume that this was a stroke of the optic nerve, especially with this odd history of headaches. So we decided to get an MRI on him. And we ordered the MRI, and it actually showed that he had a subdural hematoma on that side of his head. And what we had to do is we had to immediately send him to a neurosurgeon. And what he didn't tell us was that he fell 2 to 3 months ago and hit that side of the head. And he just didn't tell anyone. But that's what caused the subdural hematoma. It continued to grow. And that's what was giving his nerve swelling. So luckily we got him in for, a neurosurgery appointment that day, and they operated on him in the afternoon. And as soon as he got the operation, obviously his head hurt from the surgery, but the headaches went away. So, our sign of seeing the optic nerve was swollen was, what alerted us to him having the subdural.
Yeah, interesting. And then in follow-up too, did the optic nerve swelling go down after he had the evacuation of the subdural hematoma?
So it should. This actually happened recently, so we haven't seen him yet. He was still in the hospital recovering. But it should. There still might be some residual nerve swelling, But what we do is we measure the nerve swelling with something called an OCT. Basically what that is, it's a cross-sectional analysis of the optic nerve, and it measures how thick it is. We usually use it in glaucoma, but for neuro-ophthalmology cases, it's important. And what we'd expect with him is to see the OCT numbers go down to a better level. He still might have some residual kind of blurred margins, but that's okay because his vision's good, and any ophthalmologist he sees, he should let them know of this history. So, to not to scare them or alert them of what's going on.
Mm-hmm. Wow, very interesting. Really interesting cases. What would you say are like your takeaways from these? I mean, I know we talked a little bit about the first one kind of being the history. And in this case, what's interesting is there is a big chunk of history that he just failed to tell you. So what do you kind of take away? What are some important aspects to keep in mind for some of the pre-meds out there and medical students?
Yeah, that's a good point. I would say just always be alerted for anything just a little bit suspicious, because for him, we get complaints of headaches all the time. And a lot of times, it's just headaches. And, I always tell them to follow up with their primary care doctor. But with him, he was just very specific of the location, and it was just lingering, and it started to move, and that just didn't sound right. So that was just a red flag. And I think just never make any assumptions too, because it would have been easy for me to think that this was a non-arteritic ischemic optic neuropathy or the nerve stroke, so to speak. But then, he might be dead right now if we didn't get the neuroimaging. So anything that just doesn't sound right, you got to work up and be on the safe side. And I think the best way to realize, what a red flag is just by honestly seeing a lot of patients and talking to your colleagues, because it didn't sound right to me. So I was able to, talk to someone else who, the neuro-ophthalmologist who sees even more of these than I do, and just coming up with a plan with him. That's the big thing. So just, take your time when it's something that doesn't sound right.
Mm-hmm. Yeah, absolutely. It's kind of like having a little bit of a intuition, I think, that you develop as you see more patients. And I think, like you said too, even when you haven't seen a ton of patients, and maybe for those that are kind of just starting in on their training, still kind of keeping in tune with your own sense. And if something just is not clicking or it just doesn't seem to make sense, always look for something else. I think that's such a great point that we often forget too, because as practitioners, sometimes you're just so in a hurry and, you see something that could be the correct diagnosis and kind of just stop there. But you should never ignore that voice that's telling you to look for more, or maybe that something is just not sticking.
Absolutely. And especially too, just with, healthcare now, I'm always under the gun to see as many patients as I can, but it's better just to have a waiting room full of people and just wait a little bit more to make sure you don't miss something that can, that is life-threatening. It's a basic message, but you do sometimes forget it if you're just in such a rush. And again, just so important to take your time.
Yeah, absolutely. And just to kind of circle back to, I think, especially for people that are starting out, or even just they haven't even gone into medical school yet, or they're maybe just starting medical school, just circling back to the patient history, again, we get so rushed to kind of go through, talk to patients and see the next one and get on to the next patient. But I think every practitioner has heard that if you listen, then the 90% of the time the patients will give you the answer. So I think it's important to always give patients the time to talk to you, tell you thoroughly what's going on, learn to ask the right questions, and give them a chance to be the one to lead you to the diagnosis. Because more often than not, they are able to give you something at least to go by, or for you to investigate more.
Absolutely. And I think it's also important, you really do have to ask the right questions, because I noticed for a lot of my patients, for instance, the guy with the headaches, all he wanted to do was talk about, getting a pair of new glasses. And I was really trying, that's not going to be the answer. But once I was able to kind of guide him to talk more about the headaches, then as you said, he didn't exactly tell me the answer, but he basically raised a really big red flag right there. And that really helped me out as a clinician.
Right. Absolutely. Well, thank you so much for taking the time to chat with us today. These were super interesting, and I hope everybody out there learned a little bit on different things to look through. And I mean, yes, this is ophthalmology, but I think what's interesting too is that the takeaways are universal, and that even I think what is also very interesting, and probably one reason you really like ophthalmology, is how related it is to the rest of the body, and how many all-encompassing diagnoses you really need to think about. Whereas it's not just its eye pathology, it could be in the brain, it could be myasthenia gravis that affects the eyes and affects other organs. So I mean, I think it's just really interesting to hear from your perspective and how we can relate that across the board.
Absolutely. And thanks for having me on this. This was wonderful.
Thank you, everyone. Join us next week.
Our mission is to inspire, encourage, and inform students as you journey through a rigorous and intricate process of achieving your dreams in medicine. Visit us at prospectivedoctor.com and MedSchoolCoach.com for more essential resources in your medical school journey and beyond.